Hello and welcome to this HCP Live peer-to-peer discussion. My name is Michael Sapienza, and I am the CEO with the Colorectal Cancer Alliance. Today's discussion, which is aptly timed for the end of Colorectal Cancer Awareness Month, is centered around the importance of education and screening for colorectal cancer, but particularly in younger patients. Here, as you can see, I am joined by three experts in the form of Dr. Imperiale, Dr. Colangelo, and Dr. Kochhar. Thank you for joining me today for this discussion. Why don't we just start with each of you introducing yourselves? So, Dr. Imperiale?
Yes, good afternoon. I'm Tom Imperiale. I'm a gastroenterologist and an outcomes researcher at Indiana University in Indianapolis.
Great, thank you. Dr. Colangelo?
Hi, I'm Frank Colangelo. I'm an internist and outpatient primary care provider at the Allegheny Health Network in Pittsburgh, Pennsylvania.
Great. Dr. Kochhar?
Hi, good afternoon. My name is Gursimran Kochhar. I'm the current division chief for the Division of Gastroenterology, Hepatology at Allegheny Health Network, practicing gastroenterologist with special interest in IBD patients.
Great. Thank you, Dr. Kochhar. So as mentioned, today's discussion is centered around the need for improved screening efforts for colorectal cancer. But again, we're going to focus a little bit on the younger population. So, to start, I'll turn to Dr. Colangelo and Dr. Kochhar. So the first question I have is, as you guys know, in recent years, how has the conversations surrounding recommended CRC screening modalities changed? Is this really timely, obviously, with a bunch of new modalities entering this space and adapted modalities? So how do they differ, these recommended screening modalities in terms of efficacy, patient acceptance, and accessibility? And so maybe Dr. Colangelo, you can go first.
Well, over the last few years, we've seen the primary care doctor that we have additional recommended screening tests that we can offer to our patients so that they can have a choice of the modality which they would like to do. And I think offering the patient's choice in terms of screening has increased the patient's likelihood of accepting these. Now, we have to also caution the patients that each screening test that we offer perhaps has different sensitivity for detecting cancer, different specificity for as the results of the test. So we have to have that discussion with the patients. But offering further choice in terms of screening, I think, has aided the efforts of primary care doctors to get more patient screens.
Hey, Dr. Kochhar?
Yes, no, I agree with that. I think as part of your first question is how the messaging has changed. I think the two big things that happened, in my opinion, have been the lowering of the age limit from 50 to 45. That's one brand new messaging that started last year. We're trying to get to these younger patients I'm sure we're going to discuss more about the young onset CRC. And the second was the rule change of a positive FIT test or a positive Cologuard test still being considered as part of screening modality for colonoscopy, on part of payers versus being a diagnostic test. So I think that has also increased further acceptance. And then as, Frank mentioned here, with having more options to choose from to provide our patients, I think is a blessing so that we can then at least have some form of testing available to patients just in case they're not able to do the colonoscopy for a screening for colon cancer.
Great, thank you. Dr. Imperiale, this question is for you. So could you provide your insights into the latest advancements in non-invasive colorectal cancer screening measures, such as FIT or stool DNA Cologuard, or now soon, hopefully, FDA approved and or preventative task force rated blood tests?
Yes, this is a fast-moving area. And I think for the most part, it's been a good thing, but I think we have to be aware of the limitations. So there's a messenger RNA stool-based test that was published in the fall, and I think that's got potential to broaden the choices for non-invasive stool-based testing. There's also a multi-target FIT test that has been it's been developed among European countries. It adds calprotectin and a third marker, and is supposed to have improved sensitivity for picking up neoplasms. I think we need to see more data about that. I think we need more rigorous studies of that multi-target FIT test. There's also the publications a couple of weeks ago in the New England Journal, one of them being Exact Science's next generation version, which the big improvement was an improved specificity, compared to the current version. And then, of course, there's the first blood-based test that seems to be in the decent range for detecting colorectal cancer, with sensitivities in the low 80s overall, but a lower sensitivity for stage 1 cancer. So I think we have to be very careful about this. And my concern is that I think a lot of this goes to the primary care doctors, helping patients navigate these choices, because having choices is like the Starling curve. It's nice to have a few choices, but after a while, it can be of diminishing returns when you get to the right side of the Starling curve. And I think we could approach that where there's going to be too many choices. And so navigation of those choices by well-informed primary care docs and gastroenterologists is going to be key. Yeah, and I think we have to wait to see, what is the FDA going to approve? They may not approve these tests because there is redundancy among them.
Yeah. One question that I would ask, I'm just going to throw this in there for actually all three of you, is just in general, what are you seeing as the most pressing challenges for actually getting patients to be screened? And anybody can take this one.
Yeah, I think I can share my perspective. So me and Frank, we worked a lot on this in regards. So I think there are various challenges. So we know that colonoscopy is the gold standard for screening for colorectal cancer and, for screening for polyps that can become cancerous. So a lot of the challenges in that regards comes A, access to the procedure, B, patient's willingness to undergo a procedure. Because of the sedation part involved, they have to have a ride with them. So arranging of a ride and getting a day off from work to do that. I think those are some of the challenges that always come out and I think can be broadly applicable to almost all the GI practices in the country. So I think that goes without saying. I'm sure Frank will have a different perspective from PCP side, but I think on the procedural side, the biggest thing we get often asked is, do I have to have a ride? Do I have to have someone, take off from work for me to come and pick me up? So I think those kind of challenges have always been there. They're still there, and I'm not sure if we can ever completely get rid of them.
Yeah. Tom?
Yeah, I think a lot of this, again, is in the hands of the primary care docs to take the time to weigh the risks and benefits. I have to do this only occasionally because by the time patients see me, they've already decided to have a colonoscopy. What I find is that if you do true informed consent and you put them through the risks, benefits, when you get to the alternatives, sometimes, this can run into a problem because you can have patients saying, I didn't know about this alternative to colonoscopy and I wish I had. And I will always ask patients, do you want to go through with it? And they look at me a little strangely, and the reply I get most of the time is, well, I've prepped for it. And, the worst is over. So they want to go through with it. Having said that, I do think it's important. And when I do sit down with patients, I say, let's look at your risk for having something bad. And then let's look at how compliant you think you can be with a screening test, saying that fits every year. You have to be willing to do it every year. Cologuard's every 3 years. And if you're older in age, there's a risk of false positives. Colonoscopy is going to be a one-time hassle. You're going to have to bring a driver. You're going to have to do the prep. But you have to think about what's important to you and how much of a hassle factor you want. Do you want a big-time hassle one time, or do you want to spread the hassle factor out over 10 years or 3 years and that kind of thing? And I sit down with patients, go over their risk, their likelihood of adhering, and then we try to get them to decide. Lots of times I say, you don't have to decide today, but we will be calling you to see what you think. That process can sometimes take longer than inserting the scope to the cecum.
Yep. Frank, I have a question for you. So how do you approach discussions with patients, especially those who may be hesitant to undergo just screening in general? And what strategies have you found effective in engaging patients in that, shared decision-making process?
Right. Well, if I enter in the conversation with the patient, and sometimes I get it right away. Well, I heard nightmare stories about my sibling, about my neighbor who had to drink a gallon of stuff for preparation, and then they didn't feel good after it was done. And I'll say to them, well, listen, there are other options for screening that you could do in the comfort of your home that don't require the preparation. But I actually, in every one of my exam rooms, we have a laminated infographic from the American College of Gastroenterology that says we could approach this in one of two ways. And at AHN, we rarely order CT colonography. So it's either stool-based testing or a colonoscopy. But I'll say if you do a colonoscopy and it's normal, it's a one-step procedure, you're good for the next 10 years. If you do a stool-based test and the result is abnormal, you have not completed your screening until you go on and do a colonoscopy. So one of my last things with those patients is I'll say to them, I will agree to allow you to be screened with this stool-based test as long as you promise me that you will complete a colonoscopy if the result is positive. And most of them will say yes. And I'll have a few of them, when the result comes positive, they said, well, I changed my mind on that, but I'll bet you I can get 90 or 95% of my patients with a positive result to schedule a timely colonoscopy because of having that shared decision conversation ahead of time.
Yeah, what do you guys think about this conversation right now that is happening maybe at your centers or others in terms of the backlog of endoscopy suites and the wait times for colonoscopies? Are you seeing that?
We are not seeing it.
Yeah,
We don't have a backlog at our VA. We've been instructed to, at least primary care, has to favor fit over colonoscopy to help with a modest backlog, but not so much at our medics.
Yeah, I think at AHN, when the pandemic has started at 2020, 2021, there was probably some backlog, but we have all caught up with that. Definitely, there remains an issue because with the new population of 45 to 50 being now added in part of the screening mix, so that denominator has increased. But I think it's an ongoing rolling basis. I think operationally, providing access to colonoscopies in cities like Pittsburgh is not an issue at the moment, I would say. And if I can just piggyback to one thing on the previous comment I wanted to mention was, I think the messaging has to be very important when we talk to the patients. And I remember this from my internal medicine clinic days. Stool-based testing are very good at picking up colon cancer, whereas the colonoscopy may even prevent you from getting the colon cancer because we're trying to remove those polyps. Recently, actually, we did a patient story also around that, where a 45-year-old, very healthy male patient came into us. One of my partners did the colonoscopy, had a very large, cecal polyp, almost about the size of 5 centimeters, was then referred to me for resection. We got it out. So I'm just saying that polyp, asymptomatic, would have become into a cancer. So I think if we message it to the patients correctly that, listen, we're going to make sure that you don't get a cancer with a colonoscopy versus picking a cancer, I think sometimes also helps them in that informed decision-making.
Yeah, you brought up a really good point, Dr. Kochhar, about the screening age being lowered to 45. Right now, the latest information shows that nationwide, people between the ages of 45 and 49 maybe have a 25% screening rate. So we've got a significant portion of that population that is unscreened. And then if you look at the 50 to 54 population, it's about 45 to 49%. So we still have significant gaps amongst all demographics, but just in those age ranges. This is a question for all three of you. What are you doing, or what are you seeing other practices doing to combat that? Because I know that those individuals, for example, they're the busiest of them, right? They have kids, they're, have businesses, et cetera. My mom was one of those people. She was 56 when she was diagnosed and never had any screening. And the reason why was because she was busy and cared about everybody else first. So I would really love to hear from the three of you on how you're kind of combating that, especially the 45 to 49, but even early 50s as well.
Michael, I could take that also. think you mentioned something. I mean, that age group, they have kids that they're taking care of at home. They're working, and many of them also have parents that they're taking care of on both ends. I mean, they are busy. They aren't having symptoms, or sometimes reluctant to take a day off of work. I have found it very effective. Many of those individuals accepting the possibility of doing stool-based testing to complete their screening, and they can do it on their own time in the comfort of their home without as much disruption to their busy lifestyle. That's the way I've been leveraging that population. So,
Dr. Imperiale or Dr. Kochhar?
I've been making sure that they don't need colonoscopy, and you do that by making sure they're not having symptoms or any signs or high-risk family history. And once you can open up non-invasive testing, then I say, look, you really ought to do something. And if they're not going to do the FIT test every year, then I recommend that they have Cologuard, because it's very sensitive and it gives them a 3-year window. And we've already identified that these people are busy people that really don't want to take the time for this. So do a sensitive test for cancer and give them the 3-year reprieve.
Yeah, I think as Frank mentioned, I think that population is very hard to get. The number 25%, we were aware of that. So we are slightly doing better than that. I think one reason for us to do things different was to partner with Frank and other PCPs. We work very closely with them in regards to, getting out a strategy, getting out the messaging, getting out the messages to patients who are in network and who have not been screened, looking if patients have one thing is that if patients have a PCP, they are more likely to follow on screening tests. So if patients don't have a PCP, getting them a PCP, these are all network-wide initiatives that I think have to be done by multiple stakeholders. You have to have your primary care right in the center of this, because their interaction and their touching point with patients is slightly more than us gastroenterologists. And as Tom mentioned, by the time they see us, the decision has been made to either go for a screening, yes, and then what screening to go for. But working closely with the primary cares, ensuring, for example, I'll give you a simple example. We started to roll out a pilot where, primary care offices can schedule a colonoscopy. It's only at select few sites right now, but we're trying to do that so that a patient is not given a message and then they go home, then they have to call somewhere and then book their appointment. So, but this is all in conjunction, partnering with the primary care practices. So I think you really have to align the forces there.
Yeah, no, absolutely. I just want to switch to young onset for a minute. I'm sure all of you are aware of the growing prevalence. Unfortunately, the number one cancer killer under 50 is now men, and number 2 cancer killer is now women. So what are you doing beyond or before the age 45 cohort to make sure that those populations are aware of, Tom, you mentioned this, but family history, et cetera, or even symptoms? How are all three of you navigating those conversations?
Mike, I could take that first also. As Tom mentioned before, as long as they're average risk patients without symptoms, without a positive family history, I'm using lead time messaging. I mean, my 41 and 42-year-olds, I'm saying, did you hear that the screening age starts 45? Do you know what we're going to be ordering for you in 2 years or 3 years? If I first have that conversation when they turn 45, they're not going to be screened until they're 48 or 49, because it can take them a while to do that. So, prepping them for those few years, those average risk patients for those few years before the age of 45, I think is important to get them to begin screening on time. So.
Yeah, I think from my standpoint, it's more related to symptoms, because we see young patients with symptoms. Symptoms could be diarrhea or blood in stool or things like that. So I think the guide I follow is that if something was acute, less than 4 weeks, has self-resolved itself. And as Frank mentioned, if you're an average risk person, then I think we're okay. But if something is chronic, is going on for more than 4 to 6 weeks, then I think that definitely warrants a further testing, which may be a colonoscopy based on your symptoms.
And Dr. Kochhar, can you just touch, I know primarily the audience listening to this are physicians, medical professionals, but what are those, besides, the obvious rectal bleeding, what are other symptoms that if they persist more than 4 to 6 weeks, primary care or other physicians should be referring to a GI?
Yes, I think if longer than 6 weeks, if you're having, unexplained weight loss, abdominal pain, change in your stool caliber, I think those all are the conditions that a PCP should be referring the patient to GI, and then, we'll take it from there on.
Tom, anything you want to add on the young onset piece around screening?
And, again, most of the time, patients I'm seeing, if they haven't had their scopes already for diagnosis, like in the cases of, let's say, functional bowel disease, where you want to make sure that's all it is, as they're on the latter side of the 40 to 44-year-old age range, I'll say, you have this diagnosis of irritable bowel, but in 2 years, we're going to have to take a look or screen you. And I think it's especially relevant for the liver patients that we see, to let them know, because very commonly we can get caught up in their metabolic associated steatotic liver disease and sort of forget about the colon. But you say to them, you're in an important subgroup. When you turn 45, be thinking about colon cancer screening, because we're going to talk again. And here are the choices. Go talk to your friends, get online, start looking, because when you're back here on your 45th birthday, we have to have this discussion.
Yeah, being in an advocacy world myself, you heard me say earlier, my mom died. Obviously, she was 56, so she was of screening age. What do you say? I mean, people come to me all the time and are saying, we need to lower the screening age lower than 45. What is kind of your reaction to that? I would assume potentially you've had those discussions or have heard those questions.
I'm horrified when I hear it, because, as you know, the evidence for 45 to 49 is not strong. It's indirect. The ACP has come out and said, we don't think it should be done routinely. And you have to respect them. They're a little more rigorous than other professional societies have been with their recommendations. At the same time, I think you have to let patients know, we don't know whether surveying patients for symptoms and, promptly working those up, or if patients simply being a little more observant when they're younger, watching for stool changes, taking a look at what's in the toilet bowl before they flush it, looking at the toilet paper, maybe that alone would be enough. But when I hear people want to lower the screening age range, I recoil, because I think most of us know that probably lowering it to that age, unless we could do a better job with patient selection, is very likely to result in net harms rather than benefits. And, it's tempting, because the N of one tugs at all of us. We don't want to be the people who miss those cancers or know somebody who has colon cancer. And I think we have to be disciplined in our thinking about this and do the things that make the most sense first. And that would be making sure patients know about symptoms and report them.
Thank you, Tom. So, Frank, I think we have about 2 minutes left. I think, Frank, you have actually a question for me.
Yeah, Mike, I was just wondering, with your expertise, how do you envision the future of colorectal cancer screening advocacy and support from nonprofit organizations, especially in light of emerging technologies and evolving healthcare policies?
Yeah, so I think it's two-part. One is awareness. So we've launched Lead From Behind. We've done major campaigns with Ryan Reynolds and Terry Crews and Dak Prescott, and hopefully we're about to do a bunch of others to get high-level awareness out that colorectal cancer is the preventable cancer. So I think that's a major job of ours. I also think navigation is something that the Alliance has played a big part in. We are trying to build a state-of-the-art navigation program, because not all systems in the United States have the resources to be able to have navigation programs. Some of the folks, institutions here do, but not all do. A lot of them don't. So if we can play a big part in that. And then the last thing I would just say is, I do think that and Tom, you said this earlier, and Dr. Kochhar, and Frank, you also said this, which is risk stratification, right? So how do we do a better job? We have so much technology in this world, and how do we do a better job at knowing family history, at knowing maybe not just family history, but using AI, et cetera, as a tool within our EHR to be able to recommend which screening might be right? Because we are hearing, at least the Alliance is, in Philadelphia, in New York, that there are major backlogs to colonoscopy. So being able over time, to get really good at risk stratification, and being able to do that, I think could play a big part.
Thank you.
So before we end, I'll just want to say thank you, all three of you, for this enlightening conversation. I know we could probably talk for hours about this. I'm sure our audience members will really appreciate all the insights shared here today. Again, before concluding, I want to say thank you once again to all of our guests today, and thank you to our audience for listening to this HCP Live peer-to-peer discussion. Thank you.
Thank you, Mike.
Thank you, Perfect.
Thank you all.